we're fortunate to have Professor Curtis Nicol with us, who is speaking today about some of his work and knowledge around urogenital pain syndrome. So my question for you today is, what makes the urogenital pain syndrome, how's that different from the usual pain conditions that we treat as pain specialists?
Hannah, that's a great question, and one that I hope to kind of tease the members of this association with when I present in about an hour from now at the FPM conference. So the urogenital system, separate from other systems in the body, is primarily, the primary reason for it to be here is for procreation and associated appropriate recreational things, and elimination. Those are the two things that's there. And the other big thing is geography. It's location, location, location.
Okay.
Same in geography. And the reason is the pelvis, where our urogenital system is situated, is one of the most complex areas in the body. It's composed of the embryological tissues from almost every type of embryological tissue, almost every type of tissue that's in the body. If you just look at its neuromuscular system or its neural system, sympathetic, parasympathetic, it is, all interdigitated with the standard nervous system, with spinal cord crosstalk. So all these organs we have, these complex organs in the pelvis, are talking to each other. So to start with, those are the three main reasons why we see, it's such a complicated area to deal when a patient comes in and says, "Doc, I have pain down there, and it's related to sexual activity or not, it's related to urinating or not, and it's getting worse, and it's giving me a real headache."
And so I guess the things you've mentioned that makes this kind of system so unique and complex and everything, how should we, use that knowledge to kind of tailor our management differently?
See, that is our ultimate goal, because what we have been doing, and we've been doing it incorrectly and very poorly, is using other pain evaluation and management techniques to try and help and ameliorate the pain and disability in patients with urogenital pain. And it has not worked that well. So what we've learned is some of the characteristics of urogenital pain, how to phenotype patients without any biomarkers, because we have no real biomarkers. It's all clinical assessment. So we've developed what's called sort of the snowflake hypothesis. Although every urogenital patient that comes to us has a very similar presentation, pain in the bladder, prostate, pelvis, external genitalia, with associated urinary symptoms, which sometimes we forget in our silos of specialties. Each one looks the same, but each one is uniquely different. And we've now determined that the only way we're going to be able to evaluate these patients is to clinically phenotype them in what they actually are, and then focus our treatment program on those particular phenotypes. And that's where we found our success. So what we're going to present, in an hour from now, is some of the science behind the differentiation of a patient with a urologic chronic pelvic pain or urogenital pain syndrome, and the other type of pain that you perhaps deal with, back pain, headaches, that I've been hearing so far at the meeting.
Yep. And I guess as we wrap up, are there any, new and exciting areas of research that you're involved in that are kind of working us towards these different treatments for particular phenotypes that you can give us a bit of an insight into?
Right. So right now we're working on looking at the urinary microbiome that may be associated with the urogenital microbiome. We're looking at neuroimaging and seeing how get neuroimaging patterns on patients with pain down there. We see difference in here. We're starting to see how patients have maladaptive coping and how we can work on those. We're trying to develop biomarkers that we can target on patients. All these are sort of into the future. Right now, we have to use our clinical acumen, properly clinical phenotype our patient, and then target our patients specifically to each individual patient's clinical picture.
Great. Thanks so much. We're really fortunate to have you here with us.
Okay, thank you.